Thanks, Dr. Smolik. So I'd like to start with not only disclosures, and these are my disclosures with industry, but also disclaimers. I'm not Dr. Oderich. I've only been doing this for 8 years. I've thankfully been able to develop a pretty decent aortic practice, so I can tell you what I've learned so far. Your mileage may vary. All politics are local, and what I tell you here might not necessarily be applicable to where you are. And despite that, the majority of my practice is still, like most of yours, peripheral vascular disease. So I like alliteration. Requirements for an aortic program. You need a surgeon. You need someone with surgical skills. You need the proper setting. You need supplies. You need a good squad to help you. And you need subjects, otherwise known as patients. So this is geared mostly towards very early faculty, but mostly trainees who are graduating shortly. You need to know yourself. There's no doubt that in vascular surgery, aortic surgery is sexy. That being said, it's not going to be the right practice for everyone. It comes with a lot of stress. It comes with a lot of liability. It comes with a lot of radiation. And it comes with a lot of time commitment. Something that might sound really good when you're a 4th or 5th year integrated resident because they're the fun cases, might not be something that you really want to be doing when it's 3 or 4 years out and you're called in at 3 in the morning because your patient who you thought you did a great case on suddenly can't move their legs. Also, and this is equally important, do not confuse training at a great aortic program with receiving great aortic training. Some places you don't get to see sort of the full spectrum of the patient care from seeing them in the office, seeing them in the operating room, seeing the post-operative care, et cetera. Additionally, it's different when it's you in charge of every decision. There's a lot of things that you sometimes take for granted that's happening in the background that once you get into practice sort of becomes a lot harder to get your head around. Training is long. We all understand that. It's very easy to sort of train passively and think that things are just going to get into your brain because you showed up every day, and that's not the case. You really need to be an active learner, and you really need to be involved in these patients' care. You know, that includes talking to your attendings beforehand, talking to your attendings during, and talking to your attendings afterwards. We'd rather have you ask a stupid question when you're a 4th year resident than getting that same stupid question when it's a fresh attending in the operating room. To the skills portion. You do really want to see how aortic programs are run outside of your training area. This is something that, again, is sometimes tough to do when you're first starting out, but you really want to take some time for it. Financially, it's something that can be helped by grants from societies, and even making the connections. Your partners in industry are going to be vital for this. You'll soon find out that even though you're attending when you were training basically had a very strict regimen for how they did things, that 10 surgeons will have 10 different approaches for the same thoracoabdominal aneurysm. And it's really good to see how everyone does things. Keep current. When I was in training, the institution I was at wasn't really allowing physician modification. So we were mostly doing snorkels. Because of that, there's a lot of stuff that I needed to sort of learn when I was starting out, keeping current with the literature, talking to colleagues. And that leads to the next point. You really want to make contacts in the aortic space. This is vital for planning when you're first starting out, getting advice, troubleshooting, and equally as important, commiserating, because these cases do not always go fantastically. Lastly, keep in touch with your mentors. They really do want you to succeed. That holds true for my mentors when I was in training, and that holds true for the people that I've mentored. Nothing gets me as warm and fuzzy as when a former trainee texts me a completion angiogram, and they said, like, thanks, Dr. Beckerman, I didn't think about doing this in, attending hood, but there I was with a rupture on a Saturday, and, the patient made it through. Next, setting and supplies. And this is basically saying, is your hospital system equipped to run an aortic center? Will your hospital support the program? If you're first starting out in a place that was not doing complex aortic care, you need to be prepared to write a business plan, defend the model that you're trying to make. If you look at things on paper, this can sometimes be tough because a lot of these cases carry no RVU credit whatsoever. It's either carrier-based pricing or it's an unlisted code. So this is something, again, you need to talk about beforehand before it seems like all your cases are losing time and losing money. At your hospital itself, do you have a hybrid suite, ideally with fusion to reduce your radiation and the patient's radiation? Do you have centerline software? This can be very expensive. Do you have an ICU and intensivist that can deal with aortic patients? To Dr. Stern's point, do you have either anesthesia, IR, neurosurgery who can get a drain in your patient 24/7? Obviously, prophylactic drains are one thing, but you're still going to want a place that can get a rescue drain in pretty quickly. And for either open surgery or if things go poorly, you do really want cardiac surgery, perfusionists, et cetera, in your area. You also need an investment in terms of supplies. Obviously, you can work with trunk stock and having things brought in for cases, but you want to be prepared not only for ruptures, but when cases don't go perfectly, last thing you want is for someone to be driving in from an hour away to get you the piece you need. You want a full suite of thoracic and abdominal aortic grafts, self-expanding and balloon expandable stents and covered stents, laser catheters for the occasional bailout if you've covered something you didn't want to cover, catheters, wires, et cetera. And again, this does require a large investment on the hospital's part. If you look at Dr. Meltzer's paper from a couple years ago, the reimbursement is not really on par with the effort and the time that it takes to do these cases. So it's not something you could pretty much do on your own and expect the hospital to cover for you when they have a case that all of a sudden is costing $120,000, where if they're looking at just that case cost, it looks like it's a money loser. You need a good squad. Aortic surgery is a team sport. You need a reliable, consistent squad of surgical partners. Unless you want to be on call 24/7, 365, if one of your patients comes back with a thrombosed stent or something like that, you want partners that can do the same sorts of things that you can do. You need a good team in the OR. That's nurses, circulators who know aortic surgery well or are willing to learn. You need good trainees or partners or advanced practice providers, depending on your setting, cardiac or vascular anesthesiologists that can let you know before you have a major problem. And you need an office staff that's used to dealing with these patients who need more care and feeding than the average varicose vein patient. To do this, I really recommend involving the whole team in your educational events, your dinners, et cetera. Not just, again, for the educational component, but just for the camaraderie. Again, compared to some other specialties in the OR, vascular can be very demanding. And if you have people that are just looking for the least effort in a time period, they'll go to other things. They really want to feel like part of the team, and it's true because you need them as part of your team. Lastly, patience. In terms of building a practice, start slow, be safe. Gain the trust of your hospital, your team, and your referring doctors before you start doing anything too crazy. If you're starting to do anything that has not been done previously, or if you're using devices off-label, you really want to discuss this with leadership. Last thing you want is to have an issue and you're hung out to dry because you didn't talk about it with the proper people. Know your hospital, know your local politics. Who are these complex patients seeing before you came in? Where are patients getting lost? Are there things you can optimize with aneurysm screening? Can you maintain a central record of all aortic patients so you're able to find patients that were lost to follow-up who had an EVAR done 15 years ago? You also want to build your partners up, and if they're not as skilled as you when you first come there, bring them up to your level. Collaborate on patients. Don't just take their cases. It's good for the patients, it's good for you, and it's good for your reputation. Say yes to everything as long as you can do it well. Use your industry partners, treat them well. They're very, very important in a number of ways. You want to communicate with referring doctors. Again, these are complex patients. They don't always go fantastically. Keep the lines of communication open. I'll generally send a little completion aortogram once my patient wakes up just to let them know things went well. Use your hospital's marketing department. That's what they're there for. Set up educational events locally first with the ED doctors, cardiothoracic surgeons, cardiologists, family med, physician PMDs. Oftentimes, they might be relying on training and education they got 10 years ago. Maybe they're treating every single type B aortic dissection that's not complicated with conservative management, which again might have been standard of the care 10 or 15 years ago, but not today. And market yourself. No meeting is too small. Oftentimes, again, you either cannot publish or don't want to publish a large series of patients if you don't have an investigational device exemption, but you can show your cases off and get feedback from people that have been doing it longer than yourself. If you can do research, obviously with better products that are able to be used on label, this is going to become more common. If you're interested in industry trials, it's not just you and not just your results. You need the patients, you need good results, and as importantly, you need a responsible and responsive research infrastructure. We hear all the time from places that have great surgeons, great outcomes, great patients, but they just can't get someone on the phone to follow up these patients or do the paperwork that's needed to have a good research program. Talk to Cardiac. They really need to collaborate with them for a successful institutional aortic program that goes from the valve to the iliacs. And last but not least, slapping the name Aortic Center on your hospital in the absence of infrastructure to streamline and optimize aortic care is like putting lipstick on a pig. So with that in mind, thank you for your time, and I'll move over there.